Okay, next to build on this, we're going to have Dr. Abe Delpassand speak to us about the PRRT. Dr. Delpassand?
Thank you, Robert. It's a great privilege to be here to talk to you about PRRT. I would like to thank the organizers of this meeting. A special thanks goes to Marianne and Robert Bowman for their dedication to neuroendocrine community. Yes, why not? Sure.
I just want to add to that CCAN supported a travel stipend for all of the patients subjects that volunteered to have this gallium PET. So they had to travel and stay overnight for the 2 tests, and CCAN kindly volunteered and did support, and they will be acknowledged on the paper for this.
The topic that I'm talking today is regarding peptide receptor radionuclide therapy, PRRT or PRRNT, as we have heard in many different publications and today's presentations. Before talking specifically about this treatment modality as it relates to neuroendocrine tumor, I would like just to give you a little bit background of what radionuclide therapy is in oncology and talk about the principles of this. Basically, when we are talking about radionuclide therapy in oncology, we're talking about carrying therapeutic radionuclides, radioactive materials, to the malignant site, to the site of the tumor, to deliver, with the goal of delivering lethal radiation dose to the tumor with minimal or reversible side effects to the normal tissue. So here we have to basically make a molecule, make an agent that on one side has good specificity to reach tumor targets, and on the other side has a radioactive material that can have therapeutic effect and delivers good dose of radiation to the tumor for the purpose of killing the tumor, but at the same time keeping the balance of not affecting as much as possible on the normal tissue, so we don't cause significant side effects for our patients. As Dr. Odoricio elegantly mentioned about the history of this is a reprint of a paper from JAMA, Journal of American Medical Association, on the 60th anniversary of radioiodine therapy for thyroid cancer, for differentiated thyroid cancer. This has been one of the oldest radionuclide therapy that targets the differentiated thyroid cancer, and we have seen significant effect in patients' prognosis of thyroid cancer with this kind of therapy. This is the kind of silver bullet that we're talking about, which can reach to the thyroid cancer and can deliver lethal radiation dose to the tumor. The reason for success of the radionuclide therapy in thyroid cancer are summarized in this slide. We have a very good target to non-target ratio. We have rapid clearance of unbound, the one that is not used for reaching the tumor from the body, so it clears from the body relatively quickly, and it has a good residence time, so it can deliver the amount of radiation necessary to kill the tumor. So these are basics of any time that we want to design a targeted radionuclide therapy, we have to see if they qualify for these conditions. We have 3 main types of radioactive materials listed in this slide. One is alpha particles. These are very energetic, highly energetic radioactive materials, but they have a very short path length. The path length is the distance that these radioactive materials can actually travel in the tissue. Essentially, alpha particles stays in the area that are inserted. They can't travel in the tissue. On the other hand, we have beta particles that they can travel into tissue depending on the type of the radioisotopes, several millimeter about a centimeter sometimes, and they are highly energetic. Their energy are typically less than alpha particles, but still good high energy. And majority of our radioisotopes that at this point at least are used for radionuclide therapy consist of beta emitters. Examples of these are I-131, yttrium-90, lutetium. These all have beta particles. Gamma is mainly used for imaging because they have a very long path length. Therefore, they can get actually outside the body, and if we have a gamma camera outside, we can actually do the scan. So majority of our gamma emitters are used for imaging. Having said that, there are agents such as Indium-111 that they have gamma, but also they have energetic OJ electron or converging electrons that they can be used for treatment, and we'll talk about that in our future slides. This schematic drawing shows what I just mentioned. As you can see, the alpha particles essentially stays at the site of insertion. Beta particles can travel some in the tissue, and gamma particles can basically go through the tissue and can be used for imaging. There is another concept I wanted to describe to you, and that is when we see the tumor growth, as the size of a tumor increases, the amount of blood flow per gram of tissue decreases. And this is very well known. When we are dealing with the bulkier tumors, we always have some areas of ischemia or necrosis, basically. This has been a problem for reaching the tumor. If the tumor is not reaching blood supply, chemotherapeutic agents, all the therapeutic agents, they cannot get with a good concentration in those areas, and that is believed to be at least one of the reasons of unsuccessful therapy. One advantage that we have in nuclear medicine is that we have a process called Crossfire, and when we get, and this is an example of a regular, let's say, antibody therapy. It can reach to the area that we have good blood supply, and some of the cells that are in center and they don't get enough blood supply, they cannot get those therapeutic agents. On the other hand, if we compare it to the radionuclides labeled of these agents, since these are radioactive and they can travel in the tissue, there's going to be a crossfire effect that crossfire actually can reach to the cells that are not supplied by the appropriate amount of blood flow. So another advantage of targeted radionuclide therapy is identification of suitable candidates prior to treatment. Many of you might have heard personalized medicine. This is a term that is mentioned these days very commonly, and we feel that actually this is the wave of the future. There is no one-size-fits-all in treating of cancer. We need to personalize treatment of the cancer to have more efficacy for our therapies, as well as decreasing the side effects for treatment. So treatments with radionuclides, since we are reaching to a certain characteristics of the tumor, whether it's a receptor, whether it's an antigen on a surface of the tumor cells, etc., we are dealing with a very specific character of that tumor, and this qualifies the term of personalized medicine. We talked about the crossfire effect, and we mentioned that when we have a targeted therapy, we have a higher efficacy, less side effects in comparison with a conventional systemic chemotherapy. Talking a little bit about the side effects of these kind of therapies, there are the most sensitive organ to the radiation in the body is bone marrow. Bone marrow contains our stem cells that they produce the blood cells, and they are extremely sensitive to radiation. So that's one of our sort of limiting organs. Anytime that we want to design a radionuclide therapy, we do dosimetry. Dosimetry means that we calculate the radiation dose to different organs of the body. by knowing the threshold that each of these organs they have, we can come up with a safe amount of radioactive material that we can administer to the patient. Typically, one of the main differences between radionuclide therapy and chemotherapy is that the effects of the radiation therapy on bone marrow appears a little bit later than typical chemotherapy. Oncologists, they are very familiar with the hematological toxicity after chemotherapy that happens typically about 2 weeks after giving the chemotherapy. In our case, it happens more about 4 to 6 weeks, so it's a more delayed sort of effect on the bone marrow. Another organ that is extremely important for us is kidneys. And especially in PRRT related to neuroendocrine tumor therapies, kidneys are one of our limiting organs. And we need to protect the kidneys in cases of yttrium therapy or lutetium therapy to make sure that patients, after receiving the therapy, they don't develop chronic renal failure as a result of radiation toxicity. So any of these organs that are considered critical organs, we need to protect them before we give the treatment. Going back to neuroendocrine tumors, I'm sure this morning you have heard about this. These are a heterogeneous group of tumors that they can originate from diffuse endocrine system. And WHO classification in 2000 divided them into differentiated and non-differentiated neuroendocrine tumors. And the differentiated types, they have these somatostatin receptors that you are hearing very frequently. And especially subtype 2 that is highly expressed in well-differentiated neuroendocrine tumors. In terms of epidemiology, again, as you know, this disease is considered an orphan disease by National Institute of Health. The incidence of 5.25 cases per 100,000 per year. Prevalence is actually much higher because fortunately, many of these patients, they live longer, and therefore the number of patients with this condition is a high number. In one statistics, they were saying that the prevalence of neuroendocrine tumors are actually higher than esophageal, pancreatic, gastric, and hepatobiliary cancers. So, as Robert mentioned, the numbers are high. It's not like, it's rare in one sense in terms of incidence, but the prevalence is high. And this is another data actually published by Dr. James Yao, Adam Lee Anderson, showing that the incidence is increasing. Whether this increase is a result of early diagnosis or more diagnosis of these patients, or more, much better registration, or some environmental factor, or all of the above, we see that the incidence is increasing. You have heard about different treatment options, surgery, which is the best therapy if we can actually debulk the tumor at the beginning. It's something that is operable. Surgery needs to be done. We heard about some data that even in cases of metastatic disease, removal of the primary tumor has some survival benefits. Sandostatin analog, whether it's a short-acting or long-acting, has been used very commonly in patients, initially for control of the symptoms, but there are some recent reports that actually suggest that it might have some anti-proliferative effects. Chemotherapy, you know that there are several different regimens of chemotherapy, first-line or second-line chemotherapy, interferon. Radiation therapy, mostly for symptom relief, has been used. Radiofrequency ablation of the liver metastases and radioembolization that this morning was talked about. These are all good ways of attacking this tumor, and also radiopeptide therapy as a more systemic therapy and targeted radionuclide therapy has been mentioned. Cancer is a very complex condition. I mean, there is, we have learned that we can't treat cancer only by one drug or by one modality. So the need for a multidisciplinary approach to this condition is very well known. In terms of the rationale for why we use radiopeptide therapy for neuroendocrine tumors, these are slow-growing tumors, many times not really responsive to conventional chemotherapy. Actually, there are some reports response rate to second-line chemotherapy less than 15%. So with the targeted radionuclide therapy in cases of disseminated disease, radionuclide peptide therapy appears to be a good choice with higher efficacy and also lower side effects. These are have been mentioned before about the effect of the somatostatin, which inhibits the growth of the hormone and inhibits the symptoms of the neuroendocrine tumors. We know that it inhibits the thyroid stimulating hormone. This is a sort of organic, this is the formula of somatostatin as it exists in the body. As you can see, there are 14 amino acids. On the other side, the synthetic one has 8 amino acids, and hence the name of Octreotide comes from having 8 amino acids. It has a much longer half-life comparing to the native one. Native has 2 to 3 minutes versus 2 hours of half-life, so this can be used as a medication with a longer half-life. And we discussed again about the somatostatin receptors being present at the cell surface of the differentiated tumors. There are 5 types of these somatostatin receptors, and SSTR number 2 predominates and is highly expressed on these tumors. And as we know, FDA has already approved Octreoscan, which is a radiolabeled, indium-labeled somatostatin receptor analog for the diagnosis of these conditions. And all of us in a neuroendocrine community are hoping that gallium-68 octreotide PET-CT that Dr. Odoricio just showed us become approved as soon as possible, because there is a clear advantage of doing a PET-CT for diagnosis and also quantification of the lesions, and the help for monitoring response to therapy, which comes after that. These are all advantages of this. And PET scan has been known to have much higher resolution because of the way that the PET scan works and the attenuation correction and all those physics that goes to the PET scan gives us a much more superior image for a better diagnosis and follow-up to therapy. These are the type of neuroendocrine tumors showing the percentage of somatostatin receptor expression in different kinds of tumor published by Dr. Ruby from Basel, Switzerland. This is an example of an Octreoscan showing an islet cell cancer in this patient in the mid-abdomen. And we talked about this, I guess, earlier. Basically, how it works is the agent, the somatostatin receptor analog, circulates throughout the body and attaches to the somatostatin receptor sites on the tumor cells. It's like a lock and the key. And then as soon as it attaches to the receptor, it can open the door and gets actually inside the cell. And with it, if we attach this to radioactive material, it can take significant amount of radioactive material inside the cell, close to the nucleus of the cell, which is the center for production, reproduction, and function of the tumor cells. And this is how it works. Essentially, any cancer is sensitive to radiation if we can give it enough radiation. So as much as we can get closer to the nucleus of the cell, the efficacy of the treatment is going to be better. At this point, since in many centers we don't have the gallium-68 to be able to calculate the standard uptake value or SUV, we have a sort of a qualitative measurement of grading the uptake of the lesions throughout the body by Octreoscan, and this is been known as Professor Krenning's sort of scale. If there is no uptake, there is no uptake is a scale 0. 1 is weak uptake, less than liver. 2, moderate uptake, equivalent to liver. 3, intense uptake, higher than liver but less than kidney. And very intense uptake, higher than liver and kidney. So grade 4 is the uptake that we see, which is higher than normal liver, normal kidney, for instance. So in this image, if you look at This is probably a grade 4 lesion, and this is probably grade 3 lesion, kind of, approximately similar to the uptake in the liver. Going to options that we have for peptide receptor radionuclide therapy, there are 3 options available or has been tried at least in human at this point. Indium-111 DTPA octreotide. DTPA is that linker that Dr. Adricio was talking about, that cage, DOTA. By the way, that's the first time I heard that expression, but it makes a great sense. Yttrium-90 and lutetium, both they have DOTA and attached to analogs of octreotide. If you want to compare these 3 radioisotopes, so the agent, the vector is almost the same. There are some literatures that suggest that Octreotide has a better uptake for somatostatin receptor to how much difference or whether that difference is clinically significant, it's hard to say. But overall, let's say that the carrier is the same. Different agents, the differences between these agents are differences between radioisotopes. Indium has gamma, we can do imaging, we can do dosimetry with it, and it has Auger and convergent electron for the therapy. The energy, the half-life of indium is about 2.6 days, it's like yttrium, but the average path length that it travels in the tissue is very small. So it's very important for indium to get internalized, to get inside the cell, and actually to be able to give the radiation. And the other one, yttrium, on the other hand, is a pure beta emitter, essentially doesn't have a gamma. We can't do conventional imaging, at least there is a way to do PET imaging actually with Y90, but typically you can't do imaging with beta emitters such as Y90. It has a very high energy, 2.28 MeV, and half-life of 2.6 days. But the path length is much longer. It's about 1 centimeter, actually. So this is the longest path length that we have among these 3. On the other hand, lutetium has both beta and gamma. So gamma part can be used for dosimetry, beta for therapy. The half-life is longer, is about 6.5 days. The path length is longer than indium, but shorter than yttrium. So these are different characteristics of these different agents. Initial studies by Y90 were performed at Basel, Switzerland. This is the results of first publication, 29 patients with NET. They gave 4 single doses of 180 to 220 millicurie. They showed a 68% stable disease and partial responses of 6%. During this study, they noticed that several patients, out of these 29, 5 patients, they developed kidney failure. And right there, they had to stop because that's a major adverse event that obviously we cannot see that in the patients. And the conclusion was that if we want to proceed with this kind of therapy, we need to protect the kidneys to be able to administer this safely to the patient. So why we have radiation toxicity? Basically, kidneys are the major route of excretion of these radioisotopes. So they can get significant amount of radiation. And if we do not protect the kidneys, then we're going to see excessive radiation to the glomeruli of the kidneys, which are the functional units of the kidneys. And it has been noted that in about 2 to 4 months after high dose of radiation to the kidneys that can fail. And based on the literature from radiation oncologists, we know that the threshold for the kidney radiation is about 23 to 27 rads, or 2300 to 2700, 23 to 27 gray, or 2300 rads. So that's a kind of measure that actually FDA right now uses. And anytime we introduce any radionuclide therapies, we have to make sure that the amount of radiation for the full courses of these therapies are below this threshold. We know now how to protect these kidneys, at least decrease the radiation exposure between 25 to 45%. This is by administration of positively charged amino acids, not radioamino acid, just amino acids that are infused starting about 30 minutes before radiation therapy and continuation for about 4 hours. Based on different studies, it has been shown that between 20 to 40% and a mean 27%, we can decrease that. There are different type of formulations. Actually, our research center is working on a different formulation right now. We think that this new formulation will be able to decrease the radiation toxicity more than 60% in radiopeptide therapy. Y90, after this basically introduction of this amino acid infusion to protect the kidneys, the study treatment with Y90 was repeated, and in this way they were able to treat 39 patients, 4 doses of 50 millicurie of yttrium-90, and they were able to achieve complete response of 5%, partial response 18, stable disease 69, and progressive disease of 8%. Patients, 63% of patients, they had symptom improvements after these treatments, and they used this amino acid infusion, Hartmann HEPA 8%, which prevented basically radiation toxicity to the kidneys with the follow-ups. Talking about our first protocol, we started providing this therapy to our patients in August of 2005 with high activity Indium-111 Octreotide. As I mentioned, Indium-111 is used for diagnostic, and there were some reports in the literature with the much lower dose, of course, doses between 180 millicurie to 300 millicurie. We filed an IND with FDA to give 500 millicurie 4 times to the patients. Majority of the literature that you see, except our literature from our center, reporting the results of the much lower dose, actually, of high-dose Indium Octreotide therapy. Our protocol calls for basically, as I said, 4 cycles of 500 millicurie. We monitor the adverse events by doing lab tests, and also we do the staging with conventional imaging agents, imaging modalities that we have, such as CT, MRI, PET, and nuclear medicine studies. We published our first 30 results of 32 patients in, as you can see, in 2008. And we showed that actually this modality can achieve significant number of stable disease in the patients who previously had significant progressive disease, and also controlling the symptoms. This is another page of that manuscript showing that, and actually at that time, only we were so excited about the publication of these results that after patients who had completed at least 2 cycles, we included in this publication, we showed that 16 out of 18 patients, 88% achieve a stable disease by imaging criteria. We had 2 patients actually that some of the lesions were gone, about 11%. And this was the Kaplan-Meier plot showing the survival benefits of these patients. In terms of the biochemical response, a complete biochemical response, more than 50% reduction in chromogranin A was basically we looked at it, and we had a 77% response by hormonal criteria. As of March of 2011, we have treated 93 patients on this protocol, and you can see the amount of radioactive materials that they have received. Majority of the cases, they were carcinoid, 67%, islet cells, pancreatic, and other rare cases such as medullary cancer, thyroid cancer, and pheochromocytoma. We evaluated the radiological response by RECIST criteria 3 months following after each cycle. And on patients who completed 3 cycles, a stable disease was 93%, partial radiological response of 2%, and progressive of 5%. And we had significantly decreased the biomarker levels, more than 90% in patients 3 months following the last therapy, and we had 37% complete biochemical response. And these are the, looking at the toxicities, we didn't have any grade 4 toxicities. Majority of the toxicities were grade 1 to 3, which are basically tolerated well by the patients. We also looked at the functional living index by the questionnaire that we give to our patients each time that they come for the treatment. We noticed a significant improvement in social activity and family activities, emotional and functional aspect of the patient's life, especially the one that they completed the 3 cycles of indium therapy. This is a kind of busy slide comparing different publications of indium therapy. But I would like to bring your attention, majority of these, they are a smaller dose. So initial therapies with high-dose indium therapy were done with much lower dose. In Europe, they didn't go actually to higher dose. They moved to lutetium and yttrium. So this is why we really don't have a good resource of peer-reviewed publications in this area. Our friends at Louisiana State University, they published one paper in that they showed that it can be effective, and they were actually first one to use Indium-111 Octreotide therapy in the States. In terms of the survival, median survival rate for patients receiving 2 cycle, 22 months, 3 cycle, 25.6 months. There were no difference in sex or race or ethnicity. Islet cell tumor had significantly longer survival comparing to carcinoid, the other carcinoids, and no significant difference in survival between patients with no metastases and 1 site of metastases, but there were obviously significant decrease in survival in patients with multiple site metastases. Lutetium DOTA-TATE, as we mentioned, is another radioisotopes that has been used. It has both beta and gamma, therefore you can use it for therapy at the same time for imaging. Initial studies reported from Erasmus University on 131 patients showed a significant response to therapy, which more than 80% of patients, they had some benefits from these therapies, either a stable disease, minimal response, partial response, or complete response. There were one patients with toxicity, chronic renal failure, and another one with hematological disorders. And median time to progression was reported at 36 months. This is the latest one that I have from European Association of Nuclear Medicine meeting presentation by Dr. Kuakabom on 310 patients. Again, similar results. As you can see, about 20% of the patients, when they were followed after 3 months after completion of 4 doses of lutetium, 20% had progressive disease, but the rest, they had either a stable disease, partial responders, which is about 28%, and complete responders of 2%. As you can see, this is probably the main difference between high-dose indium therapy and lutetium therapy. We see more stable disease. They see some partial responders and minimal responders among those stable. But in terms of the number to get the benefit is about 80%, as we see it in here. This is another basically group of Dutch patients that was reported by Dr. Kuakabom in that meeting. And we were sitting in US and we had all these patients, and we knew that this treatment can help many of our patients, but unfortunately we did not have that to offer to our patients, and we had to refer our patients overseas. This is a number of lutetium therapies that were done outside the US, and as you can see from 2005, I mean, it was increasing every year. We finally filed our IND for lutetium therapy in June of 2007 because of several different issues that we had to deal with FDA and the sponsor of this drug. It took us 3 years, actually, and several hundreds of thousands of dollars of money, and lots of manpower hours to get this finally through FDA, and in August of 2010, this month is actually the anniversary, first anniversary of this approval. We finally got that. In the meantime, I had to travel to places in Europe that they are doing this. Of course, Erasmus, one of the pioneer centers in Europe. Our friends over there, they actually helped us a lot. Here, this is Dr. Quirkebaum. I showed all the results of his studies to you. Dr. Walter Breeman is actually one of the pioneers. He's a radiochemist, and he is one of the pioneers that put together this, found out about the cage and the radioactive material and labeling these things and did all the quality assurances. And these are some of the residents who helped him in his department. In our protocol at this point is actually similar to the protocol that at Rotterdam and Bad Berka they use it, or even Basel for lutetium. It's a 200 millicurie every 6 to 9 weeks that is administered to our patients. We protect the kidneys with aminosin 15%, which starts 30 minutes before the treatment, and we continue infusion for 4 hours. And then we do dosimetry based on the actual therapy dose. We don't use any surrogate or anything. It's basically patient gets the therapy, and then using the gamma camera. Initially, actually, we did 6 patients with complete dosimetry, including blood sample, urine sample, gamma camera, etc. But after 6 patients, FDA allowed us to just do the dosimetry with gamma camera, which is very sensitive, actually, and it's done by the actual therapy dose. This is a little bit old, actually, a slide. This is as of March. We had done 12 patients at that point. 2 cycles, 6 patients had completed 2 cycles, and 2 patients completed 3 cycles. This number is now above 25, and we are basically having patients that have actually completed all 4 doses. After completion of 4 doses, FDA has requested that we need to do follow-up by imaging and laboratory tests 3 months after the last dose, 6 months, and 12 months. And those results are extremely important for us to submit to FDA for basically showing the efficacy and also side effects related to this therapy. So far has been tolerated by our patients very well. In this group, we had 1 patient with grade 3 hematological toxicity and 1 patient with grade 2. We have not had any grade 4 toxicity so far. They get their lab tests and imaging tests regularly, so under very close follow-up. I wanted just to show you one of our patients. This was a patient, 64-year-old woman, good health, 4 years ago, underwent colonoscopy. I mean, healthy person. Then a study revealed the tail it was a virtual colonoscopy, and they saw a mass in the tail of the pancreas and multiple liver metastases. This was a big surprise, obviously, to her. She subsequently received distal pancreatectomy, chemoembolization, and also radionuclide hepatic embolization of the right lobe in 2009. When she was referred to us, had metastases to the liver and porta hepatis lymph node, and was on cold sandostatin LAR. Received 3 cycles of Lu-177 on December of 2010 and February and April of 2011, respectively. This is her initial diagnostic Octreo scan, and this is her initial lutetium. After, with lutetium, we can do imaging. So this is the first time that we did the images. This is how it looked like. This is her PET scan initially. You can see the lesions in the mid-upper abdomen, porta hepatis, and also lesions in the liver. And after 2 cycles of therapy, we see, at least by PET, there is a complete metabolic response and resolution of these abnormalities that we were seeing in the porta hepatis as well as the liver. There are predictors for response to therapy. Tumor histology is obviously very important. The amount of somatostatin receptor for our case is extremely important. Basically, if a patient doesn't have a positive Octreo scan, we cannot offer them this therapy because we don't want to expose them to unnecessary radiation. And that's, I think, one of the beauties of this method. I mean, at least we can personalize, before giving them this therapy, we can look at their Octreo scan and see if they can benefit from this kind of therapy. And extent of the tumor is important, what we call it the tumor burden or tumor load. Level of uptake has also been one of the good predictor values. If there is a high level of uptake, grade 3 or grade 4 uptake, typically we are more successful in our therapy. Number of earlier therapies are important. Karnofsky score, which is a performance score, is important. Liver metastases or ascites. And also F18 FDG PET scan. It's kind of controversial in neuroendocrine community. Some people just totally say PET scan FDG does not have any value, and some people, they feel that it has actually value. I personally believe that it has value, and that's sort of a prognostic information that we get. We actually published an abstract and presented in last Society of Nuclear Medicine showing that patients who have FDG uptake in their tumor, that's a bad prognostic factor. In terms of survival, it's less than patients who have octreotide positive. We know that they have lesions related to carcinoid, but their PET scan is negative. And I think it makes a great sense because PET scan with FDG uses radiolabeled sugar. So if the metabolism of sugar in tumor is very high, that represents that it's more aggressive and it's using a lot of energy to reproduce and function, and therefore they are more aggressive tumors. And also this helps us in terms of giving the treatment. We want to be more aggressive in patients with FDG uptake, positive FDG scan neuroendocrine tumors than the one that they are negative. So how we can compare these things, I think I mentioned a part of it. These are the papers have been published for high-dose indium therapy. You see the paper from Dr. Louis Anthony and his colleagues at New Orleans. Our paper is also here. This one by Dr. Lee Morris is actually leukoregional. They injected inside the hepatic artery. So the numbers in here are a little bit, should be interpreted differently because this was a leukoregional. And that's something actually that in our center we are planning to do with both high-dose indium and lutetium in patients who have only or the predominance of their diseases in the liver. We would like to try and see if this can be more efficacious for them. And also the yttrium and lutetium at the end. Just if you look at this last column, the number of, forget about this one, but the number that we get in terms of CR and PR, complete responders or PR, tend to be lower than these numbers that we see with yttrium and lutetium. On the other hand, overall, when we look at the one that they have had a stable disease and CR and PR, they are kind of the same, or they are not statistically significant. But overall, as I said, this is what our experience has been also. We see more partial responders and complete responders, mostly partial responders, more in lutetium cases than indium cases. But indium has been extremely successful in controlling the disease, prevention of progression of the disease, and the symptoms of the disease. So this is the conclusion, data on more than 100 patients that we have right now, complete hormonal marker response in 37%, significant improvement in hormonal response, 90%, stabilization of cancer, 93%. And these are patients who have at least completed 3 cycles of high-dose indium therapy. PR and CR, as I mentioned, are uncommon. No significant toxicity. One example is that for indium therapy, we actually don't need to give amino acid infusion. With these 100 patients, we have not seen any renal toxicity. And I think that's because the path length, as I mentioned, path length of indium is very short. So it doesn't, when it's excreting through the collecting system of the kidneys, it does not have much effect on the functional part of the kidney. And therefore, we haven't seen any need to give amino acid infusion. And hematological toxicity has been between grade 1 or 3, which are tolerable. We're going to have this publication hopefully before the end of the year. It has been submitted for publication. In terms of Y90, CR and PRs observed in about 10 to 30% of the patients. Reversible grade 3 hematological toxicity with high dose. It appears that we have a little bit more hematological toxicity with yttrium-90. Radiation dose to the kidney has been known, and we definitely need to protect the kidneys before giving this treatment. And in terms of lutetium, again, there are some reports that the Octreotide, which is the analog of somatostatin that is used for lutetium, has a higher somatostatin receptor 2 affinity. Since it has gamma emission, we can do post-therapy dosimetry. And PR, MR, and stable disease responses are reported in the majority of the patients, as we said, about 80% of the patients. Tumor regression was correlated with a high uptake on Octreoscan, and again, we need to use amino acid to protect the kidneys. So in summary, peptide receptor radionuclide therapy is a novel new therapeutic modality in oncology. It has a high tumor response rate. Side effects are approximately, when you look at all the reports in the literature, about 3% from hematological toxicity, conditions such as myelodysplastic syndrome, etc. Or kidney failure, about 3% altogether. It certainly improves quality of life. We have seen very good examples in our clinic on patients that they were severely debilitated, and after treatment, the quality of life significantly improved. We can achieve long progression-free periods. We're talking about 3.5 to 6 year survival benefits as compared to historical control. Of course, these data, there are some issues that I'm going to mention. One, lack of side-by-side sort of comparison. But overall, where we are in US regarding PRRT, I made this table just to summarize what we have in here. At this point, we have 2 PRRTs that we can offer to our patients: high activity Indium-111 and Lu-177. In terms of insurance coverage, we have been able to get charge recovery authorization from FDA on Indium-111. So majority of the insurance companies, they cover that. Of course, this has been after many times fighting with these insurance companies, sending them tons of information, review of literature. I have been on the phone hours with these insurance companies to get the authorization. But overall, we have been very successful in doing that. So insurance companies, it's available in US, and insurance companies except Medicare at this point. Medicare, we are still fighting. August 22nd, I think, next week, Friday, whatever date it is, we have actually a hearing in front of the federal court on Medicare reimbursement for this. Symptoms improve for sure. We have a stable disease. The CR, complete responders or PRs, are rare. Toxicity is low. In terms of lutetium that we are offering, yes, we are offering it in US now. The insurance coverage is not yet there. We are waiting for FDA charge recovery authorization. FDA has told us that they will give that letter to us when we have the multi-center trial start in US. So that has been one of their sort of hang-ups, and we are pushing this as much as possible. We're expecting that multi-center trial for lutetium starts sometimes in 2012. Part of it, it is in the hand of the owner of this agent, which is a company based in France, actually, which recently acquired the company in US in St. Louis. And I think, the way that it looks like, they have had several phone conversations with FDA. IND is almost completed, but has not been submitted yet. We're hoping that in the next quarter it is submitted, and then hopefully we start recruiting patients on this. As it stands right now, the protocol is going to be randomization between 2 arms, so patients with disseminated neuroendocrine cancer, mostly GEPNETs, basically, gastroenteropancreatic tumors. They're going to be randomized into 1 arm, sandostatin only, and the second arm, sandostatin and lutetium. And one of the issues that I have with this is there is no crossover, and you can't, the sandostatin arm cannot cross over. So still some of our patients will not be able to get the lutetium, unfortunately. And this is why I think actually our IND being present is going to be very helpful. I mean, if the patients, they don't qualify for getting lutetium based on the multi-center trial, our IND can help them and we can treat them on our own IND. In terms of the yttrium, as you can see, yttrium unfortunately is not available yet in US, and of course no insurance coverage. And the results are, we see the symptom improvement, stable disease, and a number of CR and PRs. There is some suggestions that the hematological toxicity or even nephrotoxicity is slightly higher than lutetium. But the shortcomings of all these data that I showed you are as follows. First of all, we have never had any randomization comparison between these different modalities. I don't know whether we're ever going to do that, but that is a scientific way to understand which modality has superiority to the other one. In the published literature, the administered dosage and schemes are sometimes different, and this makes it, again, a little bit more difficult to compare these results. Tumor characterizations, patients' characterization, tumor burden on these patients are different. We don't know exactly in different type of reports what kind of uptake intensity they were looking at, estimation of tumor burden, as I mentioned, and extent of liver involvement. So these are the shortcomings. Can we hope for the cure? And I think it's yes. I mean, we always need to game high and have a high goal. If we can treat this condition at an earlier stage, which requires an earlier diagnosing this, or in physicians in the community, they can think about neuroendocrine tumor and they sort of test for that, and we can diagnose this as an earlier stage, I think it's going to be a great help. We have to increase the maximum cumulative dose to the tumor. These numbers that we mentioned, 200 millicurie, 500 millicurie, we have seen that we can give it in a safe way, but we need still to have a sort of a dose escalation trial to see what is the maximum tolerated dose, because we want to be able to find that number and give the maximum tolerated dose to the patients for the better therapeutic response. Combination of all these exciting new agents that we have, from chemotherapeutic agents to radiotherapy to localized radiation therapy, combination of different isotopes, giving, for instance, yttrium and lutetium together, or indium and lutetium together. These are all areas that hopefully can help. If we can increase somehow by sort of a epigenetic modulation, if we can increase the expression of somatostatin receptors on these tumors, so we have better affinity to reach the tumor, that can be very helpful. And also intra-organ injection, so we have a much higher uptake first pass through the tumor if we use the higher dose for injection, for instance, in hepatic artery. And also, there are some suggestions about doing PRRT before and after surgery as a neoadjuvant therapy, which was discussed in the panel this morning. We have had cases that prior to therapy, they were inoperable, and the location of the tumor and size was in a way that surgeons, they said that, they can't do the therapy. We have had, I think, 3 or 4 patients that after treatment, actually surgeons, they were willing to go in and successfully remove the tumor, and, the patients, basically, they don't have tumor or measurable tumor at this point. There were some studies that have combined chemotherapies like capecitabines with the tumor. This is a report from Australian, still phase 1-2 trial showing that safely we can add chemotherapy with radiation therapy and PRRT in this group of patients. Here I would like to acknowledge this. This work has not been done by 1% or 5%. This has been a huge sort of teamwork among several different groups and companies. I would like to acknowledge people from Biosyntema. This is a company in St. Louis, which just, as I said, recently acquired by a company in France, Dr. Jack Arion, Jim Simon, Drews Camp, and Arthur Camp. These are people in Texas that are helping me in the laboratory to put together the agent, to do the labeling, and helped us a lot during filing FDA. With FDA, Dr. Robert Wolfangel, our regulatory consultant, several people from our research company, Radiomedics, such as Dr. Jennifer Mortada, Professor Eric Krenning, Dick Koekebom, Walter Breeman from Erasmus University, the group from Excel Nuclear Oncology, as well as also Carcinoid Foundation that gave us a first grant. Actually, it wasn't a very big grant, but I think it was very good timing for us, and we appreciate their help. They gave us that grant, and it was a kind of a starting money that we started this. Of course, we had to get a lot of money from other sources as well. But we are happy to have this in US, these therapies, and we are happy that we can take care of some of our patients. Thank you very much for your attention.